Hello, this is James Orm, your Government and Community Affairs Manager for NAMI, New York State. Thank you for attending our April 2026 Lunch and Learn with our partners at the New York State Office of Temporary Disability Assistance. They're going to go over the Continuums of Care program. Our Lunch and Learn series is a series of webinars that we do to help inform our membership about various policies in complex areas, and we're happy to have our partners join us today. With that, we'll hand it over to Sarah Watson, as well as her team at ODTA.
Thanks, James. Dana, do you want to get introduced and get started?
Dana, unfortunately, we can't hear you.
I can give an overview. Okay, so Dana, myself, and Arden Eastep are from the New York State Office of Temporary and Disability Assistance, and we have a 10-county continuum of care at our state agency, and so we are happy to be talking to NAMI today about how that continuum of care can be used as a strategy to address homelessness. We are in the Bureau of Housing at OTDA, and the work that we do in various forms is to prevent and end homelessness in New York State. So that ranges from the construction of housing to the management of a continuum of care to the Code Blue program, eviction prevention programs, legal assistance programs. Anything that is kind of related to homelessness is what we do in our office at OTDA. Thanks, Dana. So if those of you who are on here could put the counties that you work in the chat, I think that would be helpful for us as we kind of talk through some of these strategies. So a continuum of care is two things. It is both a regional planning body that coordinates housing and services for homeless families and individuals, and it's also a federal funding stream for homeless services. The purpose of the continuum of care is to end homelessness, coordinate around rehousing homeless individuals and families, and to collaborate with mainstream programs. The whole point of the CoC is to address homelessness in one way or another. And so we like to give a little history of the continuum of care so that it becomes clear how we got to this place where it is kind of the primary driver of homelessness policy in the country. So in the early 80s is when homelessness really began to just become prevalent in our country. And in 1987, the federal government tried to address it through the McKinney-Vento McKinney Homeless Assistance Act. So that is the first federal legislation to address homelessness on a national level. And in 1994 is when the CoC program was established. And before the Continuum of Care program was established, each individual nonprofit who was working to address homelessness did so kind of independently. There was no community group that got together that told the federal government, here's what we as a community or a county or a city or whatever are going to do with your money. It would just be each individual nonprofit applying. So you can imagine that there was a lot of overlap of services and gaps. And so the Continuum of Care program was created so that communities applied for federal funding together. So that's why it is both a group of people that meet and a funding stream. In 2009, the Hearth Act was passed, and that really gave congressional authorization to the CoC process, which means that Congress is the oversight for the Continuum of Care program. They authorize the funding, they can put in rules around it, they can require things of HUD, and that's all because of the Hearth Act. And in 2012, regulations governing the CoC program were published. So when we're talking about HUD funding, we're really talking about it in terms of the past 14 years. So the CoC group that meets should be anyone who tangentially touches the housing services system or the homeless services system. So you want housing providers, including Office of Mental Health housing providers, public housing authorities, social services, runaway and homeless youth, substance use, mental health, definitely people with lived experience, any emergency shelter providers. Anyone who might serve the homeless in any capacity should be a part of the continuum of care. There are lots of different types of continuums of care, and we have many different types in New York alone. So in New York City, it's what's considered a single city CoC that has 5 counties, but it's one city. You can have a city and surrounding county continuum. So Troy and Rensselaer County is one. You can get a single county CoC like in Rockland County. Regional, this Buffalo, Western New York area is a regional CoC. There are balance of state CoCs, which we have in New York State. That's where a state agency is the lead for the continuum. And there are also states that have just one CoC, usually run in a balance of state kind of way by a state agency, but CoCs kind of take all forms. And so one of the questions we get a lot is, why does it look like this? Whereas Maine has 1 or Massachusetts has 2 CoCs, why does New York have lots and lots of CoCs? And it's because when HUD said you have to form a continuum of care in order to access our funding, they didn't tell people how to come together. And that's just sort of the way HUD does things. Sorry, I should say the New York State Office of Housing and Urban Development. That's kind of the way they do things, which is we're going to tell you what you have to do, but we're not going to tell you how to do it. And so you get all these different CoCs that kind of formed organically. So you can see that the NY 511 CoC is the southern tier. Our CoC that we have is NY 525. That's all over the state, in non-contiguous counties. Franklin, Essex is a CoC. Usually it's one person at a nonprofit says, I think I can do this to apply for federal funding, and then their other counties might end up joining their continuum. And that just means they meet together and apply for federal funding together. So there is no federal or state oversight that caused the CoCs to look like this in New York. Every continuum of care has a name and a number, and all of those things are used interchangeably. So the balance of state is the same as the CoC, is the same as NY 525. When you register as a continuum of care, HUD gives you that number. So NY 525 is our federal designation, but we can call ourselves whatever we want. Those southern tier states are called the Southern Tier Homeless Coalition. There's the Points North CoC that it might be Franklin, Essex, I think. Arden, correct me. But all of the different CoCs have a different name that they call themselves. Partners to End Homelessness is the Rochester CoC. So our role as the continuum is to plan, which just really means strategic planning and planning on how to prevent and end homelessness in the community that you're serving. Oversee what's called the Homeless Management Information System. That is the data system that HUD requires for the data entry of all people who are experiencing homelessness in one way or another. And then we have to oversee what's called the coordinated entry system, which is really the homeless systems version of the SPOA process, which is what might be more familiar to those of you on the mental health side, where you have a community-wide wait list for the available housing slots that are dedicated to a certain subpopulation. So in the case of SPOA, it would be, a mental health designation. For coordinated entry, it's all the available housing slots for people who are experiencing homelessness. So planning is kind of what HUD calls administrative work. So if you are connecting with your continuum of care, these are the types of things that they are doing. They're definitely planning the meetings and the committees. They are implementing standards. They're conducting what's called the annual point in time count. That's the count of people who are homeless on any given day in the last 10 days of January. And that is the federal count. So anytime you see a number at the federal level that says this is how many people are homeless, it's because every CoC in the entire country is counting their people at the same time and feeding that number up to Congress. We submit the funding application to HUD, which is a very extensive application process. The CoC should be reviewing data and developing action plans to address homelessness in their communities. HMIS is under the purview of the continuum of care. It is kind of a software system. So every software system has to have certain privacy, security, any HMIS, even though there may be different software vendors, to be an HMIS, you have to be using the same set of data elements. So you can look in an HMIS in the state of Washington, and it's going to have the same data in it as an HMIS in New York. So we want to talk about this a little bit in case anyone from your organization is looking for specific data related to homelessness. We can probably get it out of the HMIS systems. So there are different vendors. Again, HUD says you have to have an HMIS. They don't say you have to use this vendor, you have to use this specific software. They say, here's what it has to contain, but they're not going to mandate you to buy a specific product. So we've got 3 different vendors, but you can get the same information out of each vendor. So anything that HUD funds has to enter into HMIS. CoC funded programs, these are their 2 funding streams. So if HUD's giving you the money, you have to enter into their data system. But if you want true data on homelessness, you need everybody in the community who's touching that system to enter into it. So we want to see the hotel motel placements that are made by social services. DSS in any county is the largest emergency shelter provider. And so we need their information. So they're not required to because they're not HUD funded, but if we're trying to track trends and plan and really address the problem in an intentional way, we're going to need all the data that we can get. Certainly shelters, veterans programs. DV shelters are prohibited from entering into HMIS. So here's an example of the kind of information that is in HMIS. Again, this is just sort of a screenshot of a Word document. It's an interactive online system. So we're seeing where they're coming from. We're seeing disabling condition. We see the zip code of their last permanent address. How many times have you experienced homelessness? And then we have other demographic information like disabling condition. I think the most important part of the continuum of care is the coordinated entry system. And this is where we are making actual placements of people who are experiencing homelessness into beds or programs that are designated for them. And you see people moving out of their current episode of homelessness and into permanent housing. And that is the most important part of anything that we're doing. So the continuum of care oversees that process, and they have to ensure that it is effective, inclusive, person-centered, low barrier, and community-wide. Again, HUD's going to require that everybody's sharing a wait list for their units, but or their program slots, but they're not going to tell you how to do it. They're going to give you the basics. but they don't tell you exactly what to do. It is part of any county's homeless response system. So people should be accessing the system in the same way. They should be assessed using a format that's the same across everybody in that system. Then people who enter the system should be prioritized, and then a referral can be made. We want to make sure that we're referring the person with the most needs or the most pervasive needs to the next available opening in a program. So we just wanted to go over this quickly. And if anybody has any questions at all, I know I'm like kind of breezing through this complicated system, but please put your questions in the chat and we'll go back and talk about them. Oh no, James, you wanted to save questions to the end after the recording stopped, right?
Yep.
Okay, all right, never mind. So access is how people who are experiencing a housing crisis can learn that coordinated entry exists and access services. We want people to be able to go anywhere in their system and access a permanent housing slot. So we want them to be able to go to DSS and to their local Catholic charities or to the warming center or wherever and find a path to permanent housing. So access is very, very important when we're talking about our coordinated entry system. So once people access the system and they go to their local homeless services program, I'm just going to use Catholic Charities as an example, and they say, yes, I want to be put on this list, they need to be assessed for their needs. So here's an example of an assessment tool. This is what we use at our 10 county CoC, but everyone looks different. Again, they tell you what you have to do. They don't tell you how exactly to do it. So all of these look different all over the country. So we want to get this basic information to try to assess someone's vulnerability. So high vulnerability might be that they can't access food on their own. They have poor hygiene. They don't have insight into their own needs. And so, and then also if we're asking where people usually sleep, if they're sleeping outside, that could be an indicator of high vulnerability. So each of these assessment items give a person a score. And then the coordinated entry group or the CoC group takes that score and places people on a waiting list by score. And so we show an example of what that might look like. And this ensures that we are giving the next available slot to the person with the most needs. Now, does this mean that everybody's appropriate for the housing that we have in our system? No, but it is a way for us to kind of get a look at everybody all at once and make a determination about what's going to be best for them. We don't want it to be so-and-so's been on the list for a year and so they get the next available housing slot, because the idea is if someone comes inside after being outside for 10 years, we want to give them housing immediately. They're extremely vulnerable. We don't want them to have to sit on a wait list for someone who may, behind someone who may have more resources. So the idea is that the system can respond quickly to people as they present and rehouse them as soon as they would like to be rehoused. So this is an example of a wait list. So we put anybody that's a veteran, we put in red so that they can be referred to veterans housing resources. We keep track of any income they might have to make sure they're being referred appropriately. Anyone who's in the DV system, we give a number so that we're not using their name, but they're still available. They're still able to be accessed on this sheet. So before coordinated entry was required, which was pre-2018, it was a very project-centric system where if you were a housing provider and your project was serving people who are experiencing homelessness, if someone is sitting in your office on the day that you had an opening, that person would get the bed. And that is how we all did these things. I was a housing provider before I came to the state. And if someone was lucky and they had all their eligibility documents and I had the opening that day and I thought it would be a good fit, they moved in. For me, as a housing provider, that was great. I filled the bed with the person who was sitting in front of me and it worked out wonderfully. For the community, that's ineffective because then the person with the most needs isn't getting their needs met because their housing needs met because they might need some other supports to be able to even make it to somebody's office. And so before CE, it was about the project, about the opening. There's no real referral system. You'd say to somebody, I don't have an opening, but go down to Joseph's house and see if they have an opening. And then they might send somebody over somewhere else. And that is not okay to do to somebody who's experiencing homelessness. So CE really made it about the person. So we're talking about the people on that list and saying, okay, this person has these needs. They're looking for this type of apartment. Who is the provider that can best fit their needs? And the community is triaging based on the individual needs that the person has, and they get a choice. They can also say, no, I don't want to live there. And that's fine too. And we can just move on. But it is about the person who's experiencing homelessness instead of the project opening. And so this is kind of a diagram of a path that someone might take who's experiencing homelessness. So they might be seen by a street outreach person, and then they have to go to the warming center because it's a code blue night. And then maybe from there, they'll get a referral to a permanent supported housing program. They'll have to walk down there and apply. And then they go back to the warming center, and then they maybe can get to stay a night in an emergency shelter. These are paths that all of our people take every day. These a lot of times were physically being walked by our people who are experiencing homelessness. And it is not reasonable to expect someone who is in the crisis of their lives to walk all over town to try to get access to housing. And so after CE implementation, what we do is we all come together as the providers and we say, okay, here's what we have for John Doe, and we're going to get him into our program. And you're not forcing someone who is experiencing extreme instability to go all over the place to try to find a bed. So we come together, and the onus is on the providers instead of the person who is having a traumatic experience. So for all of those requirements that HUD has, planning, the point in time count, the group that's meeting, this insane application, the coordinated entry, HMIS, all of that, they really only fund a couple of things. So they mandate a lot of activities, but they're only funding rental assistance and case management for the most part. They have these other lesser used in dark blue programs. Some of them aren't even used anymore at all, although this current administration would disagree that that's the way to go. But for the most part, 90% of funding goes to rapid rehousing, which is medium-term rental assistance and case management, and permanent supportive housing, which is permanent rental assistance and case management. The participants also need to have a disabling condition. So medium-term rental assistance, short, I guess rapid rehousing is short and medium-term rental assistance, and case management and permanent supported housing is a lifetime of rental assistance and case management. And most of these programs are in private apartment buildings with private landlords. Anyone who goes into any of the homeless programs that are funded by HUD have to meet their definition of homelessness. So that, for the most part, is category 1. Place not meant for human habitation, which is living outside, living in a camper with no running water. We see this take all different forms in different parts of the state. Certainly in our more rural areas, there are people living in places not meant for human habitation, but it's more likely to be in a garage of a family friend, or in a camper, or a tent in someone's backyard. Whereas in a city or a more urban area, you might see someone actually living on the street. Emergency shelters, domestic violence shelters, warming centers, transitional housing that is designated for people who are homeless, and a hotel motel paid for by DSS or a nonprofit. We see imminent risk here too. Some HUD programs are designated for category 2, imminent risk of losing housing. Most of it is category 1. If someone is fleeing or attempting to flee domestic violence, they're also included in the programming for HUD-funded programs. So we want to just talk in more detail about the programs that are federally funded by HUD through the CoC. So rapid rehousing connects families and individuals to permanent housing. It's rental assistance, financial assistance, which could be moving expenses, sometimes arrears for up to 2 years. Supports are provided to eliminate barriers. This is supposed to be a high support level program. It is intended to be a housing first intervention, which means that in any state, a person can be housed in an apartment with rapid rehousing, and the system's responsibility is to bring the supports to them. Permanent housing is long-term housing assistance and long-term supportive services. The household has to include one member with a disability. So those are really the 2 things they fund. So sometimes we hear that people are trying to connect to their CoC and they're disappointed that they're not getting funding for their emergency shelter or for their, maybe their transitional housing project or something else. And really the focus of HUD funding are those 2 things, rapid rehousing and permanent supported housing. All of those providers need to be involved, but they aren't necessarily receiving the funding. So the key principles of the Continuum of Care program are that homelessness is a housing problem and that there is no issue that someone might have that could preclude them from being successful in housing. It is the job of our system to meet the person's needs with adequate supports. All housing should be delivered in a housing first way, meaning that in any state, a person can access housing, and agencies who are running these programs cannot require things like sobriety, currency with their mental health program in order to accept someone into the housing. Imagine if someone was outside for 10 years, then they got the next opening on that wait list, and then the provider said, all right, well, they need to do a 90-day program before they can come into our housing program. They're going to lose that person and they're going to go back to living outside. It is the job of us as providers to try to make sure that the person has the right level of supports to be successful in housing. And choice and respect. There's no penalty if someone turns down housing, and they have a right to wait for whatever housing program meets their needs. So each of these programs have the same basic components. They're just different periods of time, really. They all have an intake and assessment. The case manager should always be looking for housing with the person. It can provide move-in assistance, ongoing rental assistance, case management. The components are very similar with some slight variations. And I should say too about these programs, they are not entitlement programs, and there is not an infinite amount of money. So if you do connect to your continuums of care and you have people in your system that can absolutely meet these requirements, a lot of these programs are full and have been full for a very long time. So it is hard to find new openings, continue to access federal funding, and it's getting harder and harder to do that. But the connection is very important, because when we're talking about bringing that level of service to the person who's in a housing program or experiencing homelessness, I think that's where the two systems can really come together. So we wanted to end our presentation by sharing some New York State homelessness data. So this is based on the point in time count, which we talked about being a count that every CoC across the entire country is doing in the last 10 days of January. So here's some estimates from New York State. So in the 2024 point in time count, we had 152,000 people who are living in a sheltered homeless location, which is a hotel, a shelter, a DV shelter, a youth shelter, warming center, something like that. In 2025, that went down 8% to 139,539. And we think that that is due to a change in the number of new arrivals who are being housed in hotels in New York City. We did see our unsheltered numbers go up, though, to 5,865. Our total number went down, and again, that's largely due to the decrease of sheltered homeless in New York City. But it is alarming, even though it's only 227 people, that many more people are in an unsheltered location in January in New York. Here are rates of homelessness. So this is something that our office recently started capturing. This is not something that we really had, and it was intended to help us target our resources in the best way possible and really get a picture of who is experiencing homelessness across the state. It is easy for us to see a number and think to ourselves, oh, that's just New York City, but it's really not. So outside of New York City, Sullivan County has the highest rate of homelessness in the entire state of New York, followed by Washington County, Clinton County, Cortland County. This was unexpected to us. I think if you asked anybody what counties they thought would have the highest rate of homelessness, they'd say Albany, Rochester, Buffalo, Westchester, and that's not the case. And we want to try to really work to figure out why these numbers look like this in these rural counties, and what do these counties have in common that are giving this high rate of homelessness. Here's our unsheltered numbers. New York City has the highest rate of unsheltered the highest number of unsheltered people, followed by Suffolk County, okay, Long Island. What do you think Utica had that 125 people living outside? Keep in mind, this is code blue, meaning anyone who wants a place to be in January can access that. So the fact that there's 125 people outside in Utica in January is surprising. And the same could be said for Fulton County. In January, there were 57 people living outside, most of them in abandoned buildings. And then we wanted to show the percentage of the total people who were outside. So this is of the total people who are experiencing homelessness, what percentage of them were unsheltered? Another unexpected list of counties. Tioga had the highest unsheltered percentage of total homeless estimates. They might have only had 12 homeless people, but most of them were outside. And it's easy to say, oh, that's just a handful of people, but what is happening that that handful of people can't access housing on a night when everyone is entitled to accessing housing. Fulton County, 50%. Delaware County, 58% is their unsheltered percentage. These numbers were very surprising to us. And so our office is really trying to dig into those this year. Here are the contacts for your CoC. So we're going to give this slideshow to James and he can get this out to everybody. And if you are in one of these counties, we really encourage you to connect with your continuum of care. And here's our contact information.
I changed over to my phone, so people can hear me now.
Yes.
So, but I'm sure James is going to open up to questions. And Sarah, I want to thank you for going through that. I just wanted to say, thank you for reaching out to us and organizing this. And we could also always talk about the other programs that New York State funds. I think Sarah alluded that we have a lot of other programs in our portfolio, and we really try, for all the data reasons that Sarah said, we really try our best to, where we can from New York State funding, still require coordinated entry and HMIS for all those reasons so that we can really hone in on all this information. So just kind of that differential between federal and state, but how we're trying to use a system they created that we see the benefits in.
Dana.
So thank you both for presenting. We're going to open it up to questions now and see if anyone has anything they want to ask before we go to our unrecorded portion of questions. So one thing we want to highlight or ask while the recording is still going is, like you said, the direct service providers or the county-based services are the #1 providers of services for housing. How does the CoC work with the SPOA?
I think it varies from county to county. So in our balance of state counties where we run this continuum of care, we really try to work hand in hand with the SPOA because there is an immense amount of overlap between those lists and our list. And so we don't want our work to be duplicative. So we created a coordinated entry SPOA MOU so that we can attend each other's meetings, we can discuss shared clients, anything to reduce the burden on the people who are experiencing homelessness and put that burden back on us as providers is what we want to do.
Another question was, do people with serious mental illness qualify under Category 2 imminent risk for the HUD homelessness definition, or is there more that someone might need to qualify as imminent risk?
Imminent risk is directly related to their housing status. So they have to have an eviction pending. They have to be told that they have to vacate. So the risk factor for the HUD definition isn't based on the person's presenting challenges. It's really just their housing status and whether they have an eviction pending.
And then would you say that wait lists are really common in the state?
Oh, yeah. Yes. Yes. So every homeless system should have its own shared wait list for that specific county, just like we shared that wait list. So in an ideal world, the person who manages that wait list in the county also goes to the SPOA meetings, and the SPOA person also looks at the wait list of the coordinated entry to just cross-reference and make sure that we aren't duplicating efforts, especially in our small counties where there may only be 1 or 2 mental health housing providers and maybe 1 or 2 homeless system providers, and everybody's looking for an apartment for the same person. So it can happen where, we don't want everybody to be stepping on each other's toes. But yes, the wait list should be that shared community wait list for every program in the county.
We'll open up any more questions before we pause the recording or stop the recording. All right, we will stop the recording here. Thank you to everyone who's watching this on YouTube later. If you have any questions, please feel free to reach out to NAMI.NYS.org. And feel free to reach out to us if there is a topic that you feel is appropriate for our Lunch and Learn series. With that, we'll stop the recording and open up for more questions from